Okay, well, I make it 9:30, so I think we'll make a start. Good morning, everybody. Welcome to this Trust Board meeting in public. So before we get properly underway, we've got some people in attendance with us today. So Lucy Upton is back with us from CQC. Welcome, Lucy. I can't see you, but well, I think you're on the call, so welcome. Brenda Lines is going to be with us throughout the day. I think you're on, Brenda. Nice to have you with us, and you're going to help us particularly with the discussions around Ockenden. And we also, I'm not sure if they're on the call yet, we have a formidable pair of Liz's with us, Liz Mackey from Health Watch and Liz Walk from Save the DGH. So if you're on already, welcome to you both. Those people who are not members of the board, I think, have been asked to turn off the camera and mute their microphones. We've got 15 minutes as usual at the end for questions. We've had some written questions from Mr. Campbell, from Colin Campbell, one of our regular contributors. Just a reminder that we're recording the meeting, and this will go on to the Trust's website. Apologies. We have apologies from Caris Williams and from Lynette. And we have our Hero of the Month awards. And I wanted to pay, you've got the details of those in front of you, wanted to pay tribute to Rachel and Amy, who were the winners of December and January awards, and to say a big thank you to them for the contribution that they have been making. We've got no declarations of interest notified in advance. So let's move on to the minutes, and let me see if colleagues have any comments of accuracy or queries that they want to raise from the minutes. Gone. I'll take silence as assent and sign that accordingly. There's one matter arising which is recorded in your papers, that's covered in the IPR report, but an opportunity to see if colleagues have any other matters arising that they wanted to pick up from the minutes. We're moving at pace this morning. I can see that. That's.
I think Jackie wants to come in.
Oh, Jackie, thanks.
Sorry, I couldn't find my raise your hand button. I just wondered, the minutes talk about the consultations moving to workshop with HOSC on cardiology and ophthalmology in April. So I just wondered if there'd been any more, if that workshop had happened, or if there's any more information.
That's a good question, and we are going to talk in a bit more detail about that in part 2, albeit that it's not specifically on the agenda. But Richard, you just give us a headline about where we are with that.
Yeah, so we are looking to talk, so obviously the consultation is now finished. We're working with the independent organisation ORS, who oversaw the consultation, to pull those workshops or formulation sessions together. It won't be this month, but it will look to be May going forward. So we'll have updates later, and as Steve said, we'll come to talk a little bit more about this in the private board in greater depth.
Okay, thank you.
Great. So can we move to agenda item 5? if I can just find my place on my papers correctly. Can we start with audit, Paresh?
Yeah, sure. Thank you, Chair. I'll take the paper as read. I don't take any questions from anyone. No questions. One thing I would like to add is credit to the finance team. They've been working very hard to prepare for the year-end audit, and they've been liaising with their colleagues to make sure that we are as ready as we can be with our external audit, which is underway as we speak.
Great, thanks, Paresh. And Damien, I gather I'm not going to ask you to respond to that because I gather that you're not at all well today, and that you sound terrible but look worse. I have it on very good. I have it on very good authority. So I'm going to assume that you will only respond in extreme circumstances to Damien, and we'll take that. We'll take that. Thanks from the audience.
Can I just say thanks to Paresh for the first comments?
Yeah, you do sound terrible. Okay, now Karis is not with us this morning, but Steve, I wondered whether you'd be up for saying a few words about the People and OD Committee.
Yeah, that's fine. So again, I'll take the I'll take the paper as read. I think many of the points that are raised in the paper will flow through into the board PR chair. So I think we'll probably cover most points most points a little bit later on. Safe to say, I think it was quite a sobering sort of meeting. I think just in terms of looking at some of the challenges that we've got from a staffing position.
Yeah, and I think one of the themes of recent meetings has been both the challenge for the existing workforce in terms of operational pressures and demands and COVID and sickness and issues around recruitment and so on. So it's a big issue, isn't it? Any questions for Steve? No. In which case, can we go to quality and safety, Amanda?
Yes, thank you. As with other colleagues, I'll take it as read, but I just want to pull out two things really, Steve. One is to commend staff for absolute focus on quality and safety and patient care, particularly given the huge amount of sickness and vacancies, etc. I can't commend staff enough, and particularly under Vicky's leadership. I think she does an exemplary job. And you will see that most of the quality metrics are holding their own. There were a few areas that we took and paid special attention to, particularly pressure ulcers, looking at also discharge. But we had some really wonderful stories from A&E, which brought to life how staff are accommodating and working differently to keep patients safe and secure. We also had a further deep dive on the SNAP audit. We had a previous report that just raised some issues that we had assurance at the meeting we were making progress against the SNAP indicators. So I'll leave it there, Steve, but happy to take any questions. And obviously we had a long conversation about Ockenden and maternity, but we've got that later on the agenda.
Yeah, yes, I'd be amazed if that were not a major element of QMS. Yeah. Nikki.
Thank you, Steve. Whilst absolutely recognising Amanda's comments around the efforts of staff, there was a comment, Amanda, in the paper that you noted a slight reduction in risks and no new risks for the BAF. I was wondering if you could share with us the reasons that you felt that there was a slight reduction in risk. And I say that just reflecting on the really difficult operational environment that we have at the moment.
Yeah, this was relating to obviously our strategic objectives. This didn't relate to the corporate risk, where we did also look at. So it was around our strategic objectives, and we have three of those, Nikki, where we've got BAF risk management processes in. So it was relating to that. With regards to corporate risks, again, we had a deep dive, and there was quite a lot of movement actually on our corporate risk register, which reflected, I think, the dynamic environment of the organisation at the time.
Okay.
I don't know if Vicky wants to comment on that.
Thanks, Amanda. No, not really, Amanda. I would agree, and I think we have really robust discussions about corporate risks, and in the divisional IPR meetings, obviously drill into more detail about their risks. So nothing else from me, and nothing of concern.
Thanks, Vicky. Shall we move to the strategy committee, Jackie?
Thanks, Chair. We last met towards the end of February, and I've done the notes as they are. There is a slight error on my part, and thanks to Joe for picking it out. When we looked at the work streams, I should have said they are place-based, and I've missed off urgent care. ICS obviously have work streams, but we've got our work streams, and we have had them for some time. So my apologies for that. Other than that, I'm happy to take any questions.
Thanks. Okay, nothing for Jackie. Nikki, we don't have an F&I report this time. I just wondered if there was anything that you wanted to say. You don't have to, but there's an opportunity if you wanted to.
Well, my apologies, Steve. I was away on holiday, I'm afraid, which is the reason we don't have a report. Would you like me just to take 2 minutes to run through what happened in the last F&I meeting on the 24th?
Yeah, that would be great if you could. Yeah.
Thank you. And yeah, like I say, I'm sorry that there wasn't a paper in advance. So naturally, we reviewed the BAF, looking at the Q4 update. The main things flagged there was that the score for BAF 6 reduced from 12 to 4 as a result of confidence that the trust would operate within its available resources during 21-22. It was noted that the score would need to be revised in the new financial year, and also that the trust needed to reframe the risk around ongoing financial sustainability, considering the in-year cycle of volatility, in so much as there's increasing certainty as the year reaches its conclusion. There was no change for BAF 7 or 8 from the previous update, and no new risks have been added to the areas of the BAF overseen by the committee. Improvements to ensure mitigations, tolerance and appetite were fully captured were discussed, and an additional board session was proposed. In terms of month 11 financial performance, unfortunately, I was sort of hoping Damien might leap in here, because it already feels extremely out of date to be talking about month 11. So perhaps, Damien, if you just wave frantically at me if I'm saying something out of turn. As at month 11, the Trust was expecting to deliver a balanced position and its efficiency programme by the year end. And the committee congratulated the finance and executive teams on achieving the year end revenue position, and passed on its thanks for the hard work undertaken, recognising the difficult balancing act between finance and operational performance. I think, Damien, we're reasonably confident in the year end as well. I think it's worth flagging at this point, but no doubt we'll come to that. Divisional performance and ICS productivity were flagged as additional areas of focus for 22-23. So month 11 capital update, the committee was updated on the progress against the capital allocation of 37.5 million, as well as the work underway to ensure delivery by year end. And again, Damien, I think it's fair to say that we're feeling pretty good about that at the year end, which is amazing news given the scale of that budget and some of the late decisions around allocations. I think the teams have worked exceptionally hard there. In terms of efficiency, the Trust delivered £1.9 million in the month, which was slightly ahead of the planning submission. And in the year to date, so this is at month 11, the Trust delivered 11.9 of efficiencies, which was ahead of plan. And the forecast was to deliver the full 14.7. So I think that's, yeah, Damien's nodding, which is marvellous. We did note that the high proportion of non-recurring schemes would make achieving the 22-23 efficiency targets more challenging, but was to be expected given the financial structuring of this year. In terms of 22-23 planning, Mr. Backler presented the 22-23 budget update, which set out a current deficit of £17.5 million, and the key drivers and decision points in getting to that number. Overall, the Trust was facing an expected gap of £30 million on a like-for-like basis compared to this financial year 21-22, before accounting for unfunded requirements in the planning guidance. I will skip that boring bit. So the committee noted the 22-23 planning update, and a final budget and plans will be presented to the April F&I committee. And then finally, we spent quite a lot of time looking at the 3-year capital plan, which was presented to the committee, which covered all the proposed capital spend for the 3 years commencing 22-23. So that covered the backlog maintenance, clinical priorities, rolling clinical programmes, digital and other capital spend. The committee considered how the trust had arrived at the proposal, including the clinical, strategic and risk interdependencies, and discussed all material items of CapEx. The committee approved the capital plan for recommendation that the trust board subsequently approved the plan. And so my apologies that I had to read that rather than giving it to you in advance, but if there are any questions.
Thanks, Nikki. That captured it very well from my memory of the meeting itself. Questions for Nikki? No, and obviously, I mean, fantastically encouraging news about where we might be at the year end. There'll be a further opportunities to talk about that, but yeah, a fantastic achievement, I think, should that come to pass as expected. Great. Okay, thanks very much, colleagues, for all of those subcommittee updates. Let's move to the Chief Exec's report. Jo.
Thank you. Morning, everyone. So I suppose I'm just going to start off, as I always do, with a big thank you to all of our staff, and that is everybody in the organisation. We recognise the work that the frontline teams are doing, but actually all of the back office teams and our leadership teams have been absolutely instrumental and are working over and above. And it is 2.25 years now. And I just absolutely want to recognise the work that everybody's doing. And I do recognise that people are tired and Easter is coming. I'm going to come back to the operational elements and the environment we're working on in a minute, but I'll do that when we get to the IPR as the first slide. So I just wanted to pick out some other things, if I may. So I'll assume the paper's read, but just to draw a few things out really. So it was great. We had Julian Kelly, who's the Chief Finance Officer from NHSE, and some colleagues come from Region. Actually, it was really good to be able to showcase some of the work we've been doing. There was an opportunity for them to learn from us and to sort of give a bit more flavour, if you like, to how it really feels on the ground, but also recognising that actually there was support from our integrated care system leaders, recognising that actually we're a really good organisation and sort of recognising the work we've been doing. So it was just to sort of draw that bit out, really. The teams that I stood very much back, and whilst I accompanied people, the teams on the wards were absolutely great. I'm really proud to talk about their services, but also really quite open and honest where there were some challenges, which I'll pick up in a minute. So just to sort of under the headings under our strategy, really. So Esh has now moved to a smoke-free site. That's not going to happen absolutely overnight. Technically it has, but I recognise there'll be some behaviours. Actually, from a staff perspective, actually I haven't seen anybody smoking. I think it's going to take a little bit more for the public, but we are an NHS organisation. We have got public health responsibilities, and that is the right thing to do. So just wanted to highlight that bit. Actually really exciting for us from an MSK service perspective. We have now joined Horder in the leadership and management of what is currently SMSK PE MSK services. The previous partners were Sussex Partnership Trust. They have exited that of their own accord. They've exited that agreement now, and we've taken over that. That allows us to really sort of look at how we might develop MSK services going forwards in a partnership model, and to have a greater focus on all the services across East Sussex. It's a really, I think, really exciting opportunity, and I think it's the start of the journey rather than the end of the journey. And Damien and I are formerly board members. It's a separate organisation. It's not a subsidiary of ESHT, but just wanted to recognise that and thank Damien and the team actually, because it's taken a little while to get here, but it's been really hard work in working through that. Maternity, I think is going to be picked up at least every other sentence today, but I'll just bring it up now. So when I wrote this, the Ockenden 2 report had been published. I think it was the day I wrote it. which is why there's quite little in there, because I don't think it'd even come out at the point I'd sort of submitted the report. We will have a bit of a conversation later around that, both in part 1 and part 2. And our next seminar has also got a session on maternity rather than just Ockenden, because actually we ought to be talking about maternity services, which Ockenden report is a part of that. Vicky will talk about the safety of our services and the assurance as part of that, and some of our existing governance arrangements, as well as how we're implementing it and next steps. So I won't go into too much detail now, but we'll add to this as we sort of go through the rest of today. Just in terms of shaping place, so we talked at our last seminar and in various committees around the development of the ICB and the sister NHS Sussex, but also what we're doing at place. So we, again, we've done this for the seminar. So we are continuing to develop our place-based arrangements. And Richard and I are at a workshop with chief execs and strategy leads next week in a facilitated set of workshops to be able to really help us articulate what place means to us, what our priorities are, and what our governance and resources need to look like. This is not about increasing resource, this is about moving resource around around where we've got it in Sussex to be able to support place-based conversations, because essentially that is where we think the majority of our priorities will be. So we'll be able to update on that at the next strategy committee and next board. There's a couple of workshops that we're working through on that. Steve's obviously going to talk through the staff survey, so I won't steal his thunder, and we've got a big session in part 2 as well. But I think I probably am going to steal the thunder. I think that the overriding take-home message for us is that actually we've done really well against our peers. I think the whole of the NHS, and I think this has been quite in the public domain, has dropped across a number of questions. And I think that's in recognition of where we are over the last couple of years. But as an organisation, we've done well against that. And as such, actually, when we look at the recommendations in the report later on, it's for us to set our own priorities for this year rather than necessarily recommendations that are coming out of that report. But I'll pause on that. But you can see there's a few areas that we would want potentially to be focusing on as priority. Staff car parking, again, it's been in the news that staff car parking was charges were reintroduced for staff. We took a board decision, and I can't remember, but about 6 months ago, where we decided that we didn't want to reintroduce car parking charges. And that has done well, and I've had some emails of thanks and support from people. So I'm really pleased that we can continue to offer that. We have also, because we've been busy amongst the sort of current environment as well. So we've talked previously about taking on Spire Hospital, which was the private hospital on the Conquest site. As you will recall, we took on the building and the assets a year ago now, and we've completed that transfer with staff transferring on the 1st of April to us. And we will be running this now as a division within the trust called Sussex Premier Health. It will bring together all of our private services. However, I must stress there are NHS services that are also going through that unit. And I think it to be in the openness, we have had a few questions from people who feel that perhaps we shouldn't be using NHS services to run private hospitals. I just want to be really clear, we're not using NHS resource. It's a really great opportunity because it helps us recruit and retain staff, and it's part of the model of care for many of our senior clinicians who have a balance between private and NHS practice. It does offer patients a choice, and patients do have the right to have a choice as to where they want to be treated, and whether that be in NHS or other services. But and of course, any, well, not any, because there will be profit, where there is profit made, that will be ploughed straight back into NHS services as well. and we were going to take on the building because it was always on a lease scheme. So again, I think that's a really exciting opportunity, and we really would like to welcome what were previously the Spire staff. We've done a lot of sessions with them, but a warm welcome to the organisation, and hopefully they will feel part of our family going forwards. We've had a lot of induction, and services should be back up and running just about now as well. And I just wanted to draw out a few key areas which will be priority for going forwards, and those will be reflected in our business plan that will come out hopefully for the next board. So priorities for the trust, and we can discuss these again at the seminar next time, is absolutely the well-being of our staff. It is, for me personally, the absolute priority, because we can't do the rest of our roles and look after our patients as well as we want to if we can't look after our staff, and so that has to be a priority for me. We still need to focus on the transformation and productivity of services. I think we've just alluded to that already. We do need to live with COVID, and again, there's been a lot in the news, which we'll pick up again in a minute, but also the recovery of services, because we still need to continue to recover electives, but Tara will pick that up in her report as well. We've already mentioned we still need to continue to work on integrating and working on integrated partnerships, both at place, i.e. East Sussex level, and across Sussex as well. And obviously we need to do that and ensure that we're financially sustainable as well. So there's not much to do for the next year, but they are absolute priorities. I just wanted to draw out one thing, and then I'm happy to take any questions, but as I say, I'll come on to the environment we're working on under the IPR. I just wanted to assure people that it is really busy, but we do continue to keep our governance going. So we've obviously got our board, we've got our committees in place, and we continue to have our divisional integrated performance review meetings, which, whilst it is busy, make sure we don't take our eye off the ball in terms of what's going on, whether that be from a performance perspective, a safety and quality perspective, or a financial perspective, and also on the sort of strategic elements as well. So that is ongoing, and it's important that we keep that in place. So I'm happy to take any questions.
Thanks very much, Jo. Just before colleagues come in, the number of patients with COVID, I mean, obviously the position is actually significantly worse now than it was when we met in a public forum previously. Are we going to pick that up in a bit more detail in the IPR? We are, yeah. Okay.
I'll touch on it, and then I know Vicky and probably Tara. It might be a running theme.
Yeah. Okay, thanks. Thanks, Jo. So questions for Jo on those items, Jackie?
Just on MSK, how will that be tracked in terms of performance now? Because it's sort of to the side of us, isn't it? So I don't have a feel for, is there a big waiting list? What's the backload? And how will we measure performance for that contract?
So it is a separate organisation to us. So from a trust perspective, we won't. I mean, I can see it. I'm happy to sort of share that offline, Jackie, as appropriate to do so, because we do track their RTT. But because it's not part of the trust, it is a separate organisation, that we wouldn't do that at the moment. So I don't think it's right in this forum necessarily to provide those assurances, but you might want within, I'm just trying to think, can I just have a think about how we give the assurances? So well, it's probably more about sharing information rather than providing assurance around that. But what we can do is perhaps Tara can pick up, not now, but at the next in the next IPR, is any impact that has on our services, and that's probably the way to do that.
Yeah,
because sometimes patients come across quite late in the pathway.
Indeed, that's sort of where my question is headed, really. Yeah, thanks, Jo. That would be helpful.
Thanks. Any other questions for Jo? In which case, Jo, do you want to take us into the IPR?
Yeah. I'm just looking at well, the aptly named Chief Executive Summary page, which is 41. So I just wanted to pick out a few areas of success. Obviously, colleagues will go through this in a significant more detail, but I just wanted to the things that are on my mind at the moment. So, and then I'll come on to the areas of concern. So actually, we have been, I think it's fair to say we've probably been struggling a little bit since we did this, but for month 11, whilst urgent care, we are struggling, and you know, had this been a few years ago, the performance levels are they're not acceptable. However, given the challenges that are going on at the moment, it is worth just remembering we are 45 out of 113 trusts. Personally, I'd like to be on the upper quartile, but we're not far out of that, and it is a success for us, and we're still recognised as being a resilient organisation despite the challenges, and we're not on anybody's worry list. That said, I'll come back to that in a minute. We are doing well in terms of RTT, not that we're particularly monitoring that, and Tara will talk through in a bit about the how well we've done in terms of recovery. So we've been doing well on that. Cancer's seen an improvement, and you'll see that the FDS, which is the 28-day standard, has now been met, and we are clearing our backlogs and doing better than our trajectories. So again, we're doing well compared to others on that. Our over 52-week waits, we are trying to reduce still, and we've got down to 100 patients, 104 actually, over 52, but again, Tara will pick some of that up because that's gone up a little bit due to 1 or 2 specialties, but she can cover. But that said, we have been doing well and still continue to do well against our peers nationally. Damien will obviously talk about it from a financial perspective, but so I won't steal his thunder for the few words that he can squeak out a little bit later, but you can see that there. And I think it is just worth picking out actually the quality indicators, and Amanda picked this up, and Vicky will again, but actually despite all the challenges, our quality indicators are still good. There are a few areas that have gone off, and there'll be areas that we continue to focus on, but actually we are keeping patients safe, and that continues to remain our overarching priority. I think just in terms of areas of concern, and for the public and for everybody else, this is over every news article that you can see. We are really under significant pressure, and I'm not going to pretend that I'm not really concerned about that, whether that be from a staff perspective, and I am going to draw out the leadership team within that, because as I say, it is relentless, and obviously I think it's more of a risk rather than actual impact at the moment, but the risk from a quality perspective as well. We are absolutely full. Every ward is full, and I'll pick up a little bit of what you said, Steve, and Vicky can pick up in her section. We have got more patients with COVID. We have more contacts than we've had before. We're certainly about 25% now above the first wave, but thankfully nowhere near where we were in the second wave. But the acuity is different, and that's the fundamental difference from where we were early on, was the acuity of patients. It does mean we struggle to, in order to protect people and to keep people isolated, it becomes very difficult to move patients into the right place and keep them in those places. And we're obviously trying to look at how we can minimise the movement of patients around our wards. But it is impacting both COVID, but probably a greater concern of mine is the number of patients that don't need to be in the trust anymore, because we need to move them on to onward care. And that's probably the greatest overriding factor. There are things that are within our gift, and we are absolutely focusing on those, and I know Tara will come on to it. But the combination of COVID and the number of medically fit patients, which is about 120, plus others that are in the process of moving into that, is absolutely causing us flow issues, which then has a knock-on impact to overcrowding in EDs, and then obviously has a knock-on impact to being able to release ambulances as well. I know we've got an ambulance paper in a minute. So I think the environment is incredibly difficult. We still want obviously to be able to offer our services to our patients, but it's really important that we are able to prioritise that for the patients that need us most. So it has a knock-on to our workforce because we're spreading our workforce across wider areas. Our occupancy is very high. It has a knock-on to our financial impact because we're not able to close the additional wards that we would wish to do so. And obviously it has a knock-on to our access. And at the moment, although there's not evidence in the knock-on to quality, the risks are significant. So I'm not going to hide behind any of that. We've got lots of mitigations that people will talk through in their sections. And I'm really proud of actually how well we are working as a team to mitigate all of those elements. But it is a really hard operating environment, and I wouldn't want to leave. Whilst we'll give you lots of assurances around things, I wouldn't want to hide behind what is actually a very difficult situation. And the only thing I would say, it is not just us, it is the rest of the country, and we've never seen anything like it. So I'm not going to end on a high point intentionally. I'm going to leave that there. I'm happy to take questions, or whether it's better to go through everybody else's section and take the questions in theirs.
I think that probably is the best way, unless there's something specific, Joe. But it's very striking, I think. So first of all, your kind of overarching point about safety, patient safety being paramount, and systems and processes being in place that mean we're keeping people safe, notwithstanding the pressure, is a very important message for the board to hear. Number one, and it did strike me. We were having kind of informal conversation about this earlier, that when you put the medically ready for discharge and COVID patients together, I mean that's you know, give or take a quarter of our bed stock, isn't it? Possibly even more, getting up to somewhere like 30% of our bed stock, which, you know, when you when you think about it in those terms, helps to kind of amplify the point that you've made about why flow is difficult. And I mean, the worst thing for us to do would be to begin to see that as normal, and for us to normalize what really should be abnormal. And you know, I know that's not what's happening, and you've made that point, but to be losing 25 to 30% of your bed stock is quite extraordinary, really. And I'm not expecting you to respond to that, but unless I've got my arithmetic completely incorrect. But yeah, it's no wonder. Amanda, you've got a question.
Not really a question, Joe. Thank you for such a honest and factual report, and it's really just your thoughts on. I think we've been having similar conversations throughout the last kind of 2 years, haven't we? It's the worst we've seen. We're doing well. Our staff are why and how we do this. And I know we're putting in so many mitigations. You have the well-being agenda is absolutely fantastic. Is there anything more that we could do? Where do you think this will end? When can we give people hope, do you think?
So I'll be positive, Amanda, and answer the bit I can answer.
Yes.
Because I think you've answered your own question to some extent. I think what's important, so our job as a board, our job as an executive team, and my job as chief executive, is to try and focus on the things that we can do. And there are things we can do, and there are things that we are doing. I can't tell you when the end in sight is in sight. So the question is, what's within our gift that we can manage? The important thing that we're working on from a transformation perspective, because it is transformation that's going to get us out of this. So I think there's two approaches. One is the back to basics, and assuring ourselves that we are doing all of those basic things whether that be board rounds in place, whether that be escalation around patients that have been here longer than X many days. And that is just relentless. I'm not going to pretend, but we've got to do that because those things are in our gift. That won't get us there. That will get us some part there. Then building on that, we need to focus on the transformational elements. So what various members of the team, virtually all of the members of the team are doing is focusing on some of the transformational elements like implementation of virtual wards, the expansion of crisis response, enhanced care and care homes. And we've got a really good opportunity as an integrated trust. So I think the answer is about right sizing our community services and putting as many pathways that once the acute element of care is complete, we can move patients in, and whether that's a surgical pathway, a medical pathway, or a medically fit pathway, that we can move those patients into our community services. And that's not a quick fix, but our primary aim now is to make sure those services are in place for winter. And I think that is the route out of it, and that's where we need to be putting our efforts whilst we're trying to get to every day. So that's my focus at the moment.
Thank you, Jo. That's really helpful, and I'm sure will be part of the annual plan as we move forward. I think that's right. And just thank you for your leadership throughout this process. It's been absolutely phenomenal. So thank you.
Thank you to the team.
On that positive note, shall we move to quality and safety and start with you, Vicky, if we may?
Thanks, Chair. Jackie has a hand up.
It'll probably be, I can raise it after your bit if you like, Vicky.
Sure, no problem.
Sorry, Jackie, I was a bit.
No, it's fine. It's simultaneous as you spoke. I raised my hand, so my fault.
Thanks, Chair. So as always, at the end, myself and Dr. Walker will be very happy to take questions. So, as already alluded to, February was another extremely challenging month for our teams, and the prevalence of COVID continued to increase with a very significant impact on staffing and on operational delivery. And I know that Steve and Tara will describe more of that in their report. We did see increasing numbers of outbreaks, unfortunately, with the new BA2 variant becoming the dominant strain. However, due to local risk assessment, our infection prevention and control guidance was adapted, so reducing isolation time and safely using as much capacity as possible. So this meant a reduction in void beds, also referred to as exposed beds that would be unable to be used in other circumstances. My thanks as always to our amazing staff, especially the infection control team, the clinical site team, and our divisional senior leadership teams for their continued commitment and absolutely unfailing dedication in incredibly challenging times. The challenges have continued throughout March, as we've said, with some of the most difficult days that some of us have seen. Staffing, especially on the wards, is fragile at times, and many of our staff are extremely tired. Despite that, as we've said, and despite the continued and relentless challenges, our key quality indicators are largely stable and still holding at the moment. Reported ESHT incidents were relatively static, with the top locations as expected given their activity. The Trust is looking at how we transition from the very traditional approach to incident investigation using root cause analysis to a very different way of learning lessons and improving quality. We've discussed this at the Quality Committee, and this is really a very significant change in culture. And we are in touch now with an early adopter site for PSERF, which is the Patient Safety Incident Reporting Framework, and we will continue to discuss plans and progress at the Quality Committee. Our senior teams are keeping a close eye on reported pressure damage, as we have recently seen a slight increase with some clusters in a small number of areas. Ward staffing is at times quite challenged, and the significant gaps in some areas at times may be a contributory factor. Work is ongoing regarding more granular data to better understand where improvements can be made. In February, there were 59 Category 2 pressure ultras reported. 35 of those were in acute beds, with 18 at the Conquest, 17 at Eastbourne, 4 in our intermediate care beds, and the remaining 20 were out of the hospital, with 4 in care homes and 16 in patients' own homes. There were no category 3 or 4 ulcers reported, and the one category 3 ulcer was revalidated clinically as a category 2. Important to note that the reporting wards are not always necessarily where the damage originated. In spite of the ongoing pressures and the significant staffing challenges, feedback from our patients is largely very positive. And considering our activity, the Trust received just 33 complaints in February, with friends and family test scores still consistently above the national averages. And for context, in February, our staff saw 11,173 patients in our emergency departments. They delivered 231 babies. They saw 29,142 outpatients, and our community nurses undertook 14,345 face-to-face visits. So I think really important context when we talk about experience and some of our key indicators. As the Chief Nurse, my main concern still is the sustained pressure on our services and on our staff. Fill rates remain lower than we would like, with over 100 additional surge or escalation beds still open to cope with the demand, and with some significant numbers of medical patients at times outlying into our surgical capacity. As always, I'd like to offer my sincere thanks to our incredible staff for their continued commitment, their compassion and their professionalism in extremely difficult circumstances. I'm humbled and very proud. I'm happy to hand over to Dr. Walker, who will take us through the remainder of the quality section, Chair, and then we're both, as always, very happy to take any questions.
Thanks very much, Vicky. David?
Thank you, Chair. So on the mortality data, which is on page 18 of the IPR, the shimmy and the RAMI are still better than our peers, and I'm very happy with them. For last year, in terms of RAMI, we just got into the top 15% of all trusts in the country, so I was very pleased with that. I was asked to show some data on sepsis and septicemia. I think that was by Jackie the last meeting, and so I've put a slide in from CHKS on the RAMI rolling 12 months for septicemia, which shows that although we briefly a couple of years ago were worse than peers, for most of the time we actually have been better than peers, and that's since we introduced the sepsis 6. In terms of COVID, we are still seeing COVID death in spite of the reduced acuity of the patients. We had 14 in January, 10 in February, and there are 11 in March on part 1 of the death certificate. So although the Omicron variant is less severe than the original wild type or Alpha or Delta, for people who are elderly and frail, it can still be fatal. And I think that message is not really getting out there to the public. As Vicky alluded to, Omicron levels locally, interestingly, from the ONS data, which is probably the most accurate data, the levels in the community were double in March what they were in the December-January peak last year. So that does give you an idea of the reduction in severity of the disease, because we were completely overrun in December-January last year. And although we are at higher levels, I think we have 120 inpatients at the moment, which is higher than the 70 or so we had in the first wave. On the whole, they're not as ill, and ITU is not stretched. I think that is all I had to say. So I'm happy to take any questions on mortality.
Thank you, David. Thanks, Vicky. I've got a hand from Jackie, I think, first, and then Miranda. Vicky.
Sorry, thanks, Chair. I've got a few points in the sort of random order. I suppose the first thing is our sickness in terms of days lost is double what it was, pretty much double what it was this time last year. We lost about 8,500 days in March last year. We're up to 15,500 this year. So for me, it's something about our staff being really exhausted, and those what have had COVID once, twice, or even 3 times are coming back limited resilience. So I think I'm concerned of the longer term impact on our staff and those very high sickness levels. I think C. diff, I'd like to understand a bit more, because we're up to 47 cases from November, or up until November, I beg your pardon. theatre productivity, 2.4 cases per session is quite low, and I wonder if that's because we're doing people that are more complicated because they're cancers or whatever, so we're not able to mix up the theatre lists to get a few simpler long waiters through. And I'm really concerned about the length of time for child development being over a year, and I just wondered how many children did that affect? So sorry, that's my basket of questions. I'm not sure where to aim it at, but somewhere between Vicky and David, I guess.
I'll leave the two of them to work that out.
So Jackie, I'm trying to remember all your questions. I would agree. I think in terms of the impact on the workforce, my personal hunch is that actually, because of all the necessary measures, that some of our natural immunity to other things, coughs and colds and other viruses, not COVID, has decreased over time. But also we have, as you say, got staff who've had COVID numerous times. And it may well be that in terms of COVID vaccination, our immunity is beginning to wane as time progresses, and there are discussions ongoing about the next phase of staff booster in terms of vaccination. And also, Steve, I'm sure we'll talk more in his part, but I think for some of our staff, the impact of COVID is far more significant in terms of post-COVID or long COVID. So I'm sure Steve will talk to that. Quickly, in terms of C. diff, absolutely. And I had flagged in previous boards, unfortunately, that even with the improved performance in Q3 and 4, it just wasn't possible to recover the position enough. So we did breach our own internally set limits. We have discussed that at every infection control committee, and we haven't seen any outbreaks. But I think the position in Q1 and Q2 really made it very difficult for the rest of the year. Very happy to talk to Amanda if it would be helpful to bring a bit more of a deep dive from the Infection Control Committee to the Quality Committee. We ribotype all of the samples, and we do have post-infection reviews for all of those cases with our consultants and our senior nursing staff.
Just a quick word on about the C. diff, Jackie. Obviously, with all of these patients in Q1 and Q2 with COVID and COVID pneumonitis, a lot of them were on broad spectrum antibiotics as well. And so the more broad spectrum antibiotic use that you have within the trust, inevitably, the more C. diff that you have. So I think it was to some extent as a result of the clientele that we had at the time. And although we've pulled it back towards the end of the year, it's not possible, as Vicky said, to get back under the line.
Okay, just on theatre productivity and child development wait times.
Would you like me just to come in on theatre productivity quickly? So with regards to theatre productivity, I think, Jackie, you've already stated the obvious. We have been hit with staff shortages as well through theatres, so anaesthetists, and we have had to prioritise our cases to ensure that we are doing our cancer cases. They are often more complex, so that we are looking at that, but we are doing production planning as we go along, and as I've said before, working with Palantir, so we expect to turn that round, and we are making sure that we can continue to produce, sort of deliver our elective plan against the bed base as well at the moment. So it really is complicated, but it is predominantly case mix and acuity of patients.
Yeah. And then just on the wait time for child development being over 60, how many children does that affect?
I haven't got that detail to hand, Jackie, but I know Brenda's in the wing somewhere, so maybe we can just pick that up and take that offline and get that back to you.
Yeah.
So
Damien, were you
can I come
looking
in?
as though you wanted to add something?
Yeah, can I come in on the community peds? And Brenda is actually working on a model to demonstrate how much we're going to try to catch up on the wait list. We've got additional funding from the CCG to prioritise both autism and ADHD through this year, and our aim is to try. It's actually worse than you said. It's not just a year. We're actually over 2 years in the current wait list. So our aim is to bring it down to 18 months initially, and then down to a year, and then as a third stage, bring it down over 6 months. So there's a staged improvement in community peds that we're really going to drive. What we might do is wait for Brenda to give us the actual figures, because I know she's working on them.
Okay, thank you, Damien.
Thanks, Damien. Sounding a little bit like Barry White there, but we look forward to that in the full report. Miranda.
My question relates to sepsis and mortality, and thank you, David, for the very helpful graph showing how we stack up versus our peers with sepsis. But in your table for February 2022, it's shown as the top cause of death. I wondered, is that representative of every month? And if so, why? Because several years ago, I don't remember this always being the sort of leading cause. It was usually pneumonia, if memory serves. I just wonder why that is the case and what we can do about it.
So it's always in the top sort of 4 or 5, Miranda. So community acquired pneumonia, heart failure, sepsis, sort of, you know, move around in the top few places. It just depends on you know, the particular month. Sepsis is always, and pneumonia are always higher in the sort of the winter months. So, you know, December, January, February, March, they're always nearer the top, and then other things become slightly more common. Well, that's not entirely true. Deaths go down in the warmer months, but and particularly the sepsis and the pneumonia deaths and the COPD, and the ones that don't change very much, like heart failure, for example, and stroke, then sort of come nearer the top, if you like. But this time of year, sepsis is always is in the top 3 or 4. The quality of the diagnosis of mortality in the trust has improved immeasurably over the last 5 or 6 years. When I started, we had some ridiculous things at the top. So, for example, UTI often came out top. Well, people don't die from a UTI on the whole. And so we've done a lot of work to clean that up. And so what you see now is genuinely the cause of mortality. Sepsis deaths, when we had cleaned it up, were much higher, and then we introduced the Sepsis 6 and the Socket to Sepsis campaign, which came about 4 or 5 years ago, and that has made an enormous difference. And although the bit of curve graph I've shown you bottom right on that page goes back, I think, to January 19, if we took it back another 3 years, then our sepsis mortality was around 115 compared with a national average of 95. And so you're seeing the good bit of the curve. I perhaps could have given you an even longer one to show where we've come from, which would have been more impressive.
Thank you.
Sorry, thanks, David. Nikki.
Thank you, Steve. I'm afraid I've got a couple of my geeky data-y type questions or thoughts. Vicky, the first one I think probably falls to you. No pun intended, because this is about falls. I was just looking at the top reporting locations, and I was just wondering how we wait for known risk, i.e. areas where we know we have patients that have got a lot of known risk factors. So a ward where we would have a lot of older patients, I would expect to see more falls. So I just wondered whether we have the ability to pick up areas where we wouldn't expect very many falls, but we are getting them, and they might fall at the bottom of that list, but they shouldn't have any falls. Does that make sense? I just wondered if that's something you thought about.
It does, and we do. So I think there is a school of thought actually that says using a falls risk assessment tool to predict the likelihood of falls is unhelpful and at times unwise for all sorts of reasons, and I agree with that. We do have patients who I would say are super high risk of falls, and there are typically, not always, are frail elderly patients who are also at risk of malnutrition, also at risk of pressure damage, and typically have a history of falls for all sorts of reasons. So I would say that we don't always need a risk assessment to know that they are very high risk, and we act accordingly. There are other patients then where things are coded as a fall, but actually when you drill into the data, it's not quite as it seems. And this is the work that we're trying to do with our BI colleagues to really understand when is a fall not a fall, if that makes sense. So we have patients who have syncopal events, or patients who faint, patients in cardiology who will have changes in blood pressure. So the reasons why people fall can be quite different, and the interventions that you need to be different as well. We also had, I hope Amanda will agree, a helpful report come to the quality committee to look at assisted falls, or patients who are lowered to the floor, if you like. And again, if you look at places like the Irvine unit, I would expect there to be higher risk there, because we are encouraging patients to mobilise, and that's the right thing to do. But you're right, there are areas where I would not expect to see as many falls, and they're the areas where we look to try and understand why that might be. It's difficult sometimes because of at times having to outlie patients. So sometimes it will be that we have patients who are predominantly medical, but they will be in surgical capacity. So it will flag in an area that I wouldn't expect to see a high incidence of falls. So I hope that answers the question, that we do look at all of that data, and there are areas where we would be more surprised to see a higher incidence of falls. But because of the way we're having to use all of our capacity at the moment, that can be difficult. Does that help, Nikki?
Yeah, the fact that you've thought about it gives me assurance. So thank you, Vicky.
Okay, sure.
I had a second question, Steve,
Of
but
course.
I wonder whether Amanda wanted to comment on falls.
I did actually. Well, not just falls, pressure ulcers. Because we're an integrated trust, we're still reporting some aspects as an acute trust, and there's some really deep dives that we need to do and to understand, which changes the way we manage falls, pressure ulcers, etc. So those were the conversations we've been having at the Quality and Safety Group. How do we use our business intelligence, to report accurately and also mitigate the risk, because they are different, as Vicky has alluded to. So just to give that assurance, it's not a easy fix, because it does involve systems and processes and information, but we're looking at it and making sure that we have those conversations.
Thank you, Amanda. My second question, if I may, Steve, was probably for David. I was considering mortality, and forgive me for mentioning inevitably yet again Ockenden and that sort of reporting, and I was just pondering that. And we see at the board mortality as a sort of total number for the trust, and I was just wondering whether there's risk within that perhaps overperforming departments where we're doing extremely well could potentially mask departments where we might have concern. And I just wonder whether we could think about whether it's possible to look at the data on a more granular basis, so that we can have comfort that there aren't hot pockets, if you like, within the trust anywhere where we should have concerns.
I mean, that's an interesting question, Nikki. So obviously the vast majority of the mortality, it falls in medicine, 90 odd % of it actually. There is a small amount of mortality in addition to that in acute trauma. So very elderly people who fall over and break their hips are at high risk of death. We don't have very high mortality in terms of elective. So people coming in for routine surgery on the whole do well through the trust. And then other areas such as paediatrics, women's and children's, mortality is vanishingly rare, and when we do have a death, it gets looked at very, very closely. What I can tell you, and what I could send you if you are interested, and being a data geek you probably would be, is I have a much larger mortality spreadsheet that I look at every month, which has a lot of that breakdown in, and I look into that in some depth. So it's probably more than the board would need, but if you would like to see it, I'm very happy to share that with you. I get it on a monthly basis. It breaks things down in much greater detail, looks at some other indices to make sure that we're not missing something, looks at weekdays versus weekend mortality. And there have been things in the background which I've looked at. For example, at one stage it had looked that elective mortality had gone up. And in fact, when we looked at it, it was like 3 cases, and when we looked at them, none of them were actually elective. There were people who were brought in for palliative procedures electively, but who were dying from cancer. So people having a remove an acidic tap because of their ascites, because of their widespread metastases, who came in and had a tap for comfort reasons and then died within the next month, and therefore counted as a mortality on the shimmy data. So we do look into that in great detail, and with help from BI from Louise Holmes, and James Wilkinson also does some work on that for me as well. So I'm happy to share anything. I can give you the bigger picture if you want.
I was just, how's that reviewed, David? Does that go to quality and safety or some other committee within the trust?
No, it doesn't go to quality and safety. It just comes to me. You know, we have a clinical effectiveness group which does a lot of that reviewing, which is chaired by James. That reports into COG, and that reports into Q&S. And if we see anything that we're concerned about, it then gets raised as an exception to Q&S, but it doesn't come routinely to Q&S. There's a lot of data, but it's too much for Q&S.
Okay, no, I was just wondering, like, if there's that exception reporting through to Q&S, then that would be
there is a line of clinical effectiveness to COG to Q&S.
Thanks, Nikki. Joe, did you want to?
I was just going to say, and we do have mortality reports come through to IPRs as well. So and clinical effectiveness. So we have got a sub-board mechanism as well.
Okay, so I'm conscious of time. I'm just going to move us on, if that's okay with everybody. Steve, and workforce.
Thank you and good morning, everyone. As in previous months, I'm going to take the report as read, and I'll just pull out a few salient points later on. But before I do that, I want to bring you up to speed with our latest position as a trust. Nikki's already noted the speed with which things change, and that's certainly been the case with our workforce. So were I to have been presenting this report to you at the end of February, the period that it covers, I'd have been saying that the picture was similar to the one that we experienced in January. However, unfortunately, since then, presenting it today, it's not the case with the impact of the most recent peak in COVID cases. So since we last spoke as a board, we've seen a real peak in our staff COVID cases. They rose dramatically from less than 100 to heading towards 250 in March in a matter of days, equaling the worst position that we've seen at any point during the pandemic. Whilst this has now abated somewhat, but it's not back to February numbers, given the average time to return to work is 9 to 10 days, the position's taken quite some time to ease. So it's been an incredibly tough period for everyone. Thankfully, the numbers have now dropped from a high down to around about 160 a week ago to 111 today. But with the ongoing impact of wave after wave of pressures on the wave after wave, the pressures on staff can't be underestimated. COVID currently makes up around 27% of our sickness, which is down from upwards of 40% a few weeks ago. And total sickness is currently today running at 401, which is down from over 500 a couple of weeks ago. This equates to about 6% of our total workforce. Comparative data is actually quite difficult on this at the moment because waves are happening in different places at different times. So, you know, so you end up ultimately looking at averages, but certainly talking to CPO colleagues across across the southeast and more broadly, I think our sickness rates seem to compare reasonably well with other trusts as we compare the data outside of particular peaks that hit one trust or another. So we've had an extremely challenging period, and like others, I want to pay tribute to the clinical teams, the divisional leadership teams, and I want to particularly draw out the often forgotten site teams whose energy, persistence, and spirit I think is inspiring at times, you know, for everything they're doing to flex our workforce in order that we can keep areas safe. I do want to also recognise, alongside other people who've already said this, though, the physical and emotional strain that this has put on every one of our people. People aren't getting the opportunity to recover. There is no break. And it's really clear that this is hard on them. And, you know, we need to be very, very aware of that. We know, and Amanda's already said, that we, in terms of health and well-being, we are recognised as being a leading trust on this, and we continue to put great focus on it. But actually, it's not just about the way in which we look after our people; it's the way in which we look at our services to try and make things easier for people as well. And there's a number of things, and I'm sure Tara will cover some of them later on, that we've done over recent weeks to look at how we can deliver things differently, including reviewing all of our patients as they come into ED to identify which ones might be social admissions, and that's supported by adult social care. Looking at how we can use community teams to in-reach to support discharge, looking to increase our crisis provision, developing stroke in reach, actually looking how we can use mental health nurses on our wards to expand and support the workforce, increasing the numbers of doctors' assistants that we've got to support rapid actions. And most recently, and I'm sure Tara will talk about this, looking to move back to a model where adult social care are actually more visible on site to help us. I appreciate these are all operational points in the people section, but they all support our workforce by aiming to make things different, make things better, to take some of the pressures that they face away, and to be more innovative in the way in which we deliver care. We predicted for some time that with all of the stresses and pressures that we've talked about, we would see implications in terms of turnover, which actually this month it stayed the same as last month at 11%, but it's running 1% higher than we've seen in recent years. I think what's more important is the move towards the dominant reasons for people leaving, moving away from better opportunities and promotion towards retirement and work-life balance. So people leaving the service or reducing their working hours as opposed to moving trusts. And I think that it's really important that we recognise that. When Amanda was talking earlier, she commended our staff for the efforts given the sickness and the large number of vacancies, driven by turnover. I'd just like to be clear that our vacancy levels are actually running below actually where they were pre-COVID. They're currently at 8%, which is our lowest for 5 months, but it's still above our 5% target. I think the vacancy challenge is really around how we fill vacant shifts, given the sickness levels that we're that we're seeing at the moment. Remaining on the subject of staff numbers, our substantive workforce numbers continue to increase, but alongside the increasing turnover, we're having to run faster and faster and faster to keep still. And we know that there's a limited workforce out there. So retention is a very important focus for us and probably is a greater priority than it's ever been before for us. In terms of the rest of the report, the impact of the pressures on mandatory training and appraisal remain clear. Our 6 and 8 week planning took a hit in February, which is very disappointing, but we're reinvigorating that now. Bank and agency rates, fill rates remain challenged, but they're improving slightly on where they were. I want to finish this part of my report where I started, really. It's incredibly tough. Our people are under pressure and our service is under pressure. The way they rise to it every time is inspiring, but its impact in the longer term, especially given our age profile, is of concern. But I do hope I've assured you that we're taking every action we can to support people in delivering the levels of care we'd want to, and in looking at ways in which we can protect them and therefore the workforce of the future. Finally, I just want to mention that as a system, we've really upped the ways in which we're working together, especially across East Sussex, in order to support the workforce and in order to support workforce gaps. We're working more closely and better than we ever have before, supporting each other with recruitment, looking at where we can work together with recruitment, identifying where the primary needs are across the system, which are going to enable us to, I suppose, make sure that our patients are in the right place and therefore we can support them in the best possible ways. So I think one of the things we are seeing now is the system really coming together to help us, to help our patients and to help colleagues. And I think that's a very, very positive step forward in the evolution of the ICS and the ICB as it'll be in the future. I'll stop there and open to questions. Sorry, I'm conscious there was a lot to cover.
Thanks, Steve. Very helpful and very interesting way of summarising all of the challenges and issues. Karen.
Thanks, Steve. An amazing, I think an amazing reflection on what all our staff do and your team in terms of trying to keep all our staff together and going as well as they can in very difficult circumstances. A couple of questions, really drilling down just on a couple of things. One, you mentioned long COVID in the report and beginning to look at that and the impact on workforce. What sort of scale are we talking about in terms of staff with long COVID? and
think,
kind of how are you envisaging that that's going to play out? Are we seeing more and more? Is that building over time?
We're certainly seeing cases, Karen, and we're seeing more cases. I think my answer is probably going to be a little bit unhelpful, and I'm going to say we don't know. We don't know how this is going to pan out. We don't know what the end point is going to be. But what we do know, and I think this is being looked at a national level as well, is that we absolutely need to support people with long COVID, and that our typical approach to long-term sick and long-term sick pay and things like that probably doesn't probably doesn't work for those individuals. Do I see long COVID as being a significant impactor on our workforce going forward? No. Do I see it having a significant impact on a number of people that we have an absolute obligation to look after? Yes. I think that national studies will help us to understand a little bit more about this as we go forward. But at the moment, it's a question I just can't answer with any fact, I'm afraid.
Thanks. And if I may, Steve, have a second question. Just in terms of the rostering, it was a significant dip this last month. Is that just a one-off? Or I guess my concern is that we've got such staff shortages. When rostering isn't clear and isn't good, it makes it so hard for staff in terms of kind of knowing where we are. And I'm worried about a chicken and an egg situation. If the rostering isn't good, then it makes everything worse. But when everything is bad, then we don't get the rostering right. So it's some assurance around that dip there.
I think you're absolutely right. And sorry, I don't have the numbers right in front of me right now, but I think the month before, the 6 week was at 41%. Sorry, the 6 week was at 41%, I think it was, from memory. And it has taken a dip in month. I think we took our eye off the ball in month. We're certainly working to recover it. And one of the things that's become very, very clear, and I'm sort of going to repeat what you've just said, and I know that all of our ward leaders, our nursing leaders, and our operational leaders recognise this, is the earlier we roster, the earlier we can seek support from our temporary workforce, the more likely we are to get that. We've got some really good MI about it, and I do see it as we had such a big jump the month before that I'd have loved us to keep there. We've dipped back a bit, but I think our trajectory will continue, and I'm sure next month our trajectory will absolutely show we're going in the right direction on rostering.
Thanks, Karen. Thanks, Steve. Any other questions for Steve? No. Okay, good. Thanks very much, Steve. Tara, can we move on to access and responsiveness?
Yeah, of course. First thing, I think what I've seen and heard today is that my colleagues and I work so closely together. I might not need to do this section in coming months because everyone seems to cover it, which is great. So I will take the report as read. But first thing, and as others have done, I would like to thank our amazing staff. I think the way that they respond to the increasing and ever-changing demands on our services across acute and community is amazing. And, you know, I couldn't do my job without them, and our patients wouldn't be looked after as well as they are without them. So as per Joe's summary, the demand on our front doors remains high. As a trust, we have performed above the national average. Now, as we all know, the expectation for front door is at 95%. In February, the national average was 73%, and in March, it's dropped down even further and is currently hovering around 66%. So that reflects the impact that this is having nationally. We have remained above the national average in all settings. So I think, again, testament to our staff and to us as a system, because we're addressing that we can't do it as an island. So again, a great thanks to everybody. I mentioned in the previous board that we're implementing e-consult at the front door. There has been a delay in the implementation of that due to technical reasons above and beyond our control. but the expectation for rollout of that is now the 25th of April. So we will start on the 25th of April with full implementation going through to the end of June. We have and are continue to be in the process of recruiting a team of care navigators. These are band 3 support staff that will be next to said machines to support patients through that journey. So we're not expecting patients to walk through the front door and just be confronted with a bank of screens. The navigators will also have access to our service finder so that they can book onward appointments to appropriate clinical settings. So whether that be with a GP, a pharmacy, optoms, etc. So patients that we do go through the process and see that they can be seen elsewhere will leave with alternate providers, so that we don't leave patients frustrated, because we recognise from some of the figures and the work that we've done that patients are coming to our front door because they cannot get access elsewhere. Again, picking up on points that have been raised, as an organisation, we've delivered the H2, so the second half elective recovery in month 11. And again, that shows how well we're working as an organisation and with our system partners to continue to maintain this. We've maintained our no patients waiting over 78 weeks. Again, this is a real standout for us as an organisation, as there are other organisations with significant numbers waiting in that bracket. I mentioned and we introduced Abigail Jago at our last board, and she has now started as a deputy coup for planned care, and she is resetting our internal elective care board and maximising grip and control, and is, as we speak, working on our next 4 to 6 week production plan, and that includes rostering as well. So again, I think that covers off a lot of the points we've talked about with regards to theatre productivity, etc. We've mentioned the acute demand and the impact that this is having, but also staff sickness and the ability to deliver the elective programme at the pace we would like. But we are looking and meeting our trajectories. But we are, as part of this production planning, look at how we manage our case mix over the coming weeks to see whether we can maintain our services and maybe look at those patients that have been waiting with long waits, but also in day cases, so that we can maximise our theatres while still managing through our bed base. As in the previous month, we've delivered all of our cancer standards with the exception of the 62-day target. And again, Abigail is working on that grip and control for that. We do continually monitor our patients, and at the Quality and Safety Committee, we did go through all of those individual patients so that we could provide assurance that we are absolutely looking at it on a case-by-case basis. We are ahead of our internal and system trajectory with regards to our 62-day recovery. But one thing to note, and as we look forward, is that we have seen the second highest month for referrals in 2 years in this current month at 2,446. So I think this goes as well to demonstrate that patients are still being referred, and we are responding to that. Joe has already mentioned we've delivered the faster diagnostic standard again in month, and that is addressing our backlog, and we only seeing that improve as our community diagnostic centre comes online in the coming months. We have similar issues with increased referrals to our community services, and again they are also hit with staff sicknesses and some vacancies, and also with the infection prevention and control regulations, which have impacted on delivery there, and that's really with our care home settings as well. However, despite this, regionally, ESHT have been recognised for achieving above the 70% performance target for the 2-hour response, and our model is being integrated into the national model as well. So again, recognition for the fact that our teams are working at a really high level, and that the community teams, and we've mentioned InReach, have come in to support flow and discharge, and I would like them to thank them specifically for doing that. We currently have over 200 patients that no longer meet the criteria to reside in our bed base, and we are taking actions and doing things quite differently. As I said, the staff are responding. We have taken SNAP or Goldilocks audits with our teams where we dispatch an individual to each ward at 11 o'clock. They go through those, the patients on the ward, and we identify what we can do differently to enable and expedite discharges. And we have seen some real change in the particular day when we start to do that. And we are also continuing with our MAID events. So again, we are thinking on our feet and dynamically with our system partners to ensure that we expedite discharges. And Steve, not to contradict your maths earlier on, but we're currently working in approximately 49% of our bed stock at the moment, with, if we take into account our not meeting criteria to reside, our COVID recovered and our COVID exposed. So that goes to show as well how hard and how well our teams are working to maintain our level of flow through such a small bed base. We have now worked with our system partners, and we have 3 adult social care team members on each site. But we must acknowledge that in doing that, although it supports us as an acute trust, I have to put my other hat on and look at the community and the wider pathway for patients, and we are just moving some of their staff into the acute. So we're having to balance that off, but we are working very closely with them, looking at our patients that have been here over 21 days and really looking at how we can do things differently. So there's a huge amount going on at the moment, and my colleagues have covered a lot of it off already, and I will pack up ambulance handover in a following paper. So I will stop there and just pause for any questions.
Thanks very much, Tara, and I wish my maths had been better than yours, because obviously the position is even worse than even more challenging than I thought it would be. Jackie.
We used to track the number of attenders, and I couldn't see it in this pack. And I know you're saying, you know, we see more and more people coming to the front door, and we're trying ever imaginative ways to help people get out the back door. It just feels too squeezed, too pressured. I mean, we've identified nearly 40 rehab beds that we need, and discharge to assess. We can't get people out fast enough. So I'm just, are we trying to make the system work and it can't? We need a different system. I know that, sorry, Joe, I missed where it was in the pack, so my apologies. I'm just, if you were to start again, you wouldn't start from here, I guess. And this doesn't feel like a sustainable model. It feels like we're asking people to work at the absolute peak, and the demand is overflowing. So I'm just, is there something else that maybe place allows us to do that we would call for a wholesale redesign, because this isn't sustainable?
I'm going to let Joe come in and answer that one, because I think if I had the answer, Jackie, I would have implemented it weeks and weeks ago. But in the main, we are working as a system, and we are looking at what we can do differently. I'll cover it off in the ambulance handover, but we're working with CCAM as a partner as well very closely now to see what we can do to keep patients in their own home, so it's the right care in the right place. And we need to try and smooth the pathway out as a whole. If we could redesign it, I'm sure we would, but we would have to look at the whole system of delivery of healthcare with our primary health, etc., etc. But I'll let Jo come in, because I know her hand went up the minute you asked that question. So.
Joe?
I was going to let you go first, Tara, and I know you're going to cover some of this, so I apologise if I steal a bit of your thunder. So, Jackie, we've talked about this before, isn't it? We've got a choice, really. We can either keep people away from our front door, or we accept they're going to come and we put the resource at the front door. I think there are some things we've done that Tara's talked about, either in previous months or it's sort of absorbed within here. So, introducing Livy. And we really drove that from a Sussex perspective, so that we are now, I think, very few, and Tara will probably have the numbers better than I do, but little to no patients that come through 111 directly to us now actually come face to face. They're picked up through Livy, so they don't get included in our numbers. But I think the other day, it was just as an example, I think there were about 20 patients across the 2 sites that went to Livy, and there are more patients that go in through that. Of course, it doesn't hit in our numbers, but can you imagine another 20 a day on site, what that'll be. So I think that's part of it. Tara, nod at me if you're going to put this up in the ambulance handover bit. I say we, I haven't done any of this. We've just done an audit of around 1,000 ambulance conveyances, and we're going to be working with CCAM, so Tara can come back on that, but to work with them to look at alternative pathways, use of that, and I might pick up a little bit more later, Jackie, around that, about how we can work with them in a different way. I still think, unless you can shut your front door, and that and that hasn't been decided nationally, we go back to putting the right resources at our front door. And I know what Tara's working on at the moment, and we've got a business case in part 2, is making sure we have got the right clinicians at the front end and the right size. So I still think if we've got a robust UTC with the right numbers of the right resource, right skill set and the right space, then we can manage that there. And then where possible, we keep as much away via ambulance, and we keep as much away as we can on a remote basis coming through 111, or patients be able to pick up 111 as the access point. I still think that's the answer.
Yeah, which I don't disagree. I think if people want to come because that's where they feel they'll get help, then we should respond to that. But how does primary care feel about this? Does it feel like we're doing the GP's work, or do they need the help, or what are they? What's the view in the system?
I don't think they think we're doing their work. I think primary care is also overwhelmed as well. I think the demand has just changed. I think the way patients present and want that there's less waiting, but they are busier than they've ever been as well. I do think there is a question, and part of the place-based conversation is how we make sure we've got sufficient primary care, because we know that the patients come to the UTC, apart from injuries, many of those don't need to be in the UTC. They could be in primary care. It depends if you look at UTC primary care service. So it is a discussion we've had before, isn't it? I think Tara's the chair of the LADB. I think those conversations have got to all go through place level again. We're trying to help drive some of the primary care conversation, but I do think there are patients that come that could go to alternative services, but again, we need to make sure that they're in place.
Thanks, Jo. Amanda.
I mean, mine was a similar reflection, really, Jo, and you said it earlier in response to a question I'd raised, that, you know, the hope comes in not working harder, but working differently, and the balance between managing the day-to-day operations and spending time at place in transformation is a key thing, isn't it? Because we're not going to get out of this unless we work differently. Our workforce needs to change. You know, we're robbing Peter to pay Paul, and actually it's stepping back and being able to see it. So my question was really, when do we think that we're going to have enough transformational plans in the bag to tip this into a different conversation from just managing the day-to-day in a really, really very, very comprehensive dynamic way to something that's a little bit more systematic and planned? And so we're refocusing. Does that make sense?
Yeah, it makes sense, Amanda. I think if I had the answer, that would be great, and I could give you a date. But we are working on a whole system, number of projects, and the ambulance handover is probably a primary one to show that we're picking things up now and really looking at part of the LAEDB process is to look at the whole patient pathway and what the transformational pieces are that we can do. So we're working as a system on that. So we're not we've got the 2-hour response. I'll just name a few, but we're looking at where we can have a community SDEC. So we don't actually bring patients into the acute setting. So with a whole raft, and we will work with not just the trust transformation team, but also with the system transformational teams to look at what we can do together. And again, credit to our teams is that we are actually ahead of the game with our 2-hour response. And that helps us. So no, I can't give you a date. I'd love to, but there is a whole raft of projects that are being worked through at the moment that we will pull together as a system, but also through groups like the LAEDB and the Planned Care boards, so that we can see what we can do across the whole patient pathway. And I think we mustn't lose sight of the fact that we have to do it on an end-to-end piece. If we just concentrate on one section, something else is going to domino and fall over.
Thanks, Amanda. Karen?
Thanks, Steve. So I'm going to go to the other end of the puzzle, let's say, and ask about discharge, one of my favourite topics. I see that we're now beginning to progress the discharge to assess model with adult social care, and I'm wondering how that's progressing, what it's shown up. And I don't expect the changes to have been implemented, but I guess when you work on these models, it's like, are we seeing real opportunities for transformation versus incremental change? Is that going to be a possibility with this model? And yeah.
So in first answer is obviously one of the reasons that we had Julian visit us is because nationally there has been a change in the funding model for discharge. So we are looking at what we can do transformationally and differently. The discharge to assess model has worked in part in as much as we are able to move patients into a discharge to assess bed so that it can have their full workup and then move on to their next placement. I think just set against the background of where we are at the moment, the time spent in a D2A bed is a lot longer than we would like it to be. So the onward movement is slowed down. So the whole train is slowed. Which is what we're seeing by the number of patients that do not meet the criteria to reside in our MRD numbers. So it's worked in part. It's been really successful to be able to, when we had the space to move patients through. But as we've now got to a space where we've realised we do need to change our models, and we do need to increase certain different pockets of capacity, we are slowing up. So I wouldn't say we can prove that it's been definitely successful as it stands at the moment. And like I said, we have brought 3 adult social care of the team back into the trust to help us undertake some assessments and look at all of the gateway areas, which means they've been moved away from that D2A model because our local authority colleagues only have a certain amount of resource. To quote Amanda, we've robbed Peter to pay Paul. So we've got to get that balance right and look at getting trusted assessor models in the organisation more robust, look at nurse-led discharge so that, again, we can look at how we can support and manage that ourselves. But I go back to, we are absolutely managing our bed base at 49% at the moment, and we are delivering in excess of the national ask of our P0. So I know for a fact that our teams are working with colleagues across the whole community and local authority to get patients out and back home a lot quicker. So we are using different organisations, and I quote Mother Teresa quite a lot. So Mother Teresa is an organisation that take patients home. They will provide meals, but they will do once a day checks as well. So actually we can send a patient home and use those services so that we can still ensure that we have a patient that's being checked on and they can be escalated if there's any concerns, but also they're getting the meals. So we are doing things really sort of quite dynamically and looking at how we can use that example for other things. And as we expand virtual wards and remote monitoring, etc., that will all come into play. But it goes back to the main point. We need everybody to be back in at work and not have the sickness levels that we've had to allow us to make that progress.
Thank you.
Thanks, Tara. Very comprehensive report. Thank you very much. You can have a breather now before we come back to talk about ambulance handovers. Damien, and finance as best you can.
Thank you, Steve. So it's going to be fairly short for fairly obvious reasons, but basically we are still in the shadow period where we're working to the end of 22-23, where basically we received additional funding to top us up and almost guarantee break even. So there has been, I would say, no risk to actually delivering break even for the year. I mean, you're seeing month 11 results here. We've now got draft of month 12, and yes, we do deliver break even for the year. We have got to the point where we exceed the efficiency target for the year as at month 12. It has been broadly a message in the second half of additional funding for COVID and additional funding for the TIF bids that compensated additional spend on pay and non-pay, and that balance has been almost exact for the two elements. Also on capital, and I believe Nikki's already covered this in her section. We had quite a big gap still at month 11. You looked at, if you read this report in terms of year to date, it was suggesting that we were still 7 million short of the position in terms of bills coming in to pay for capital through to year end. But I'm happy to confirm that we had a very large number of capital items that basically got finalized through month 12, and we ended up within 1 million of the capital position in terms of invoices received, and actually the remaining balance was a reasonable capital accrual process. In fact, in comparison to the previous year, in the previous year we had 7 million net capital accruals. That was the balancing item, and this year we have less than 1 million. So I think it's reasonable to say that it's an assured position against the capital position, so we shouldn't have an issue on this front through the year-end accounts. I think that's basically my key position in terms of landing this year end. The big question we faced, which I think has already been raised in Steve's section and Tara's section, is how we now move into the start of the next year and very different financial rules. And I think the point that we just need to highlight in public board is we're modeling high level assumptions to help the ICS produce draft position for the year. But because the guidance came through so late, we haven't really managed to drive that as a bottom-up process. And what we're going to need to do through April and May, I know Nikki said we'll have it in April, but to be honest, we'll only have a draft position, is how to build a bottom-up position so that we know what each division needs to be able to deliver to make sure that it's a robust plan for the year. So that's the big demand that we're facing through April and May.
Yeah.
Nikki's already highlighted capital for the 3-year, which is a new position that we have to take. And actually we see it as mostly positive because it allows us to work on a longer term plan horizon. So those are the key messages. So I'm happy to hand over for questions if that's helpful.
Thanks very much, Damien. And I know we're only looking at month 11, strictly speaking here, but you know, we'll come back to month 12 in due course, but I just want to echo what was said earlier on about what a phenomenal achievement it is to balance both the revenue and the capital for this year. And I think it's worth saying to the point that you raised, Damien, that the income that you talked about coming in was planned and expected income, part of the negotiated year. So it's not what we might have in previous years called a bung to cover a sort of unexpected gap. This was a part of the planned and managed budget. So we the fact that there was some movement in the thinking at the centre about how, when, and whether what had been promised would actually come is another matter. But I think we were what it tells me is that we've delivered on the things that we said we were going to deliver, and I think that's a huge achievement, which again we'll talk about a bit more. But let me see if colleagues have questions that they want to raise with you. They may all wish to just save your voice, of course, Damien. So yeah, you're saved, Damien. So thank you for that report. I make it 11:15, and we are due to take a break at 11:15, and I think we probably need to do so. We've got quite a lot of important ground to cover in the next part. So can I just suggest that we take a break till 11:20? We'll reconvene at 11:25, so people just get a chance to stretch their legs and refresh their tea and so on. And I'll see you in 9 minutes. Thank you. Okay, I make it 25 past. Hope everybody had a break. I had an enormous sugar rush from chocolate, so that's been good. So we've got we're a bit behind. We've got quite a lot to cover, some really important clinical and service delivery issues. We've got some admin matters. We'll try and rattle through them as quickly as we can, but let's get back to the important issue of ambulance handover. And you're back on again, Tara.
Yeah, thank you, Steve. Okay, so the reason for bringing this here is obviously nationally there's an increased focus on ambulance handovers and the impact of the ambulance response times and patients that are waiting at home for the response or actually at scenes of accidents, obviously. NHS England have asked that all trust boards are cited on the trust ambulance handover times and actions that are being taken, and that's the reason that this paper is here today. I'll take the paper as read, and the performance is available on page 93 of the pack. As we understand, the standards are set out for our region, and 65% of our ambulances are to be handed over within 50 minutes, 95 within 30, and 100% within 60. So on average, and at the time of the report, we were holding on an average of 6 to 8 vehicles per day at 30 minutes each. And this is from a total number of 55 to 60 arrivals per day. Over the last couple of weeks, we've seen an increase on that, but obviously this is just at the time of writing the report. At Eastbourne, we currently lose approximately 660 minutes per day of ambulance time, and at Conquest, it's roughly 600. If we look at that, then, and to put it in real layman's terms, we could effectively park an ambulance outside each of our EDs. So we are absolutely aware of the impact that that has, and we are working to ensure that we can reduce that, not only doing this on our own, but with our system partners and also with CCAM. What have we done? In the first response, we actually had an ambulance awareness week. Now, that wasn't something that we did to really drive loads of initiatives. This was to absolutely raise the awareness of the ambulance inbound screen so that people knew how to, and this is not just our ED staff, this is all of us, understand how to read that. And by reading that, we can understand the incoming demand. We try to make it as simple as possible. And our overall trust aim, which we have put on the second page of the document, is really to ensure that we have adequate space at all times to receive ambulances. And we estimate that that is basically 2 trolley spaces. We have worked through a load of initiatives as we've done that, and have been recognised and praised as a system because we have developed, and I'll bring it back to a future meeting, an escalation pathway for our ambulance response times. So we go from green to purple, as you would expect, and there's triggers at each point, actions, and who is responsible. And I think that's something that's really key, is to make sure that everybody understands what part they play in that pathway. So we are also undertaking an audit of the first 1,000 ambulance conveyances to the organisation through January. We started this 2 weeks ago. So far, 400 of those have had their first clinical review and 200 have had their second clinical review. Of the 200, 26% of those conveyances did not require any emergency or acute attention at an ED department. 6% could have not been conveyed if the individuals or the ambulance crew had sought advice from a GP or another clinician. And then there are 16% of those that are within our gift to give, which is about us directing the patients directly to gateway. So the ambulance crew taking the patient directly to a gateway area, which could be SAU or SDEC for those of you that aren't aware of what they are. Now, obviously, some of that is impacted when we are in the bed state that we are at the moment as well, and the staffing situation, but we are working on those direct to gateways and taking those as actions that are within our gift to give, and we will absolutely be working on those. The other areas that we've got are rapid ambulance handover areas, or ratting areas, as you may hear them referred to. Now, we have capital works going on at Eastbourne at the moment, and that will be ready towards the end of June. And at Conquest, the area is actually now ready and developed from a capital build. Staffing has been an issue for actually being able to open those, but as Steve has mentioned in previous board meetings, we have done things in a very eshed way and come up with new ideas. So we have an ED boot camp for our overseas nurses that are joining us. That starts on the 25th of April. It's roughly about a 4-week boot camp, so that the incoming nurses, we know they're qualified, but they have very specific tasks. They move around each different station, and when they pass out from the boot camp, they will then be assigned to the ratting areas, which will also support our throughput of ambulance handovers. We now meet with our CCAM partners more regularly, I suppose, than we have done, and actually they're more engaged than they ever have been, and we have two-way conversations. And I suppose grown-up conversations, it's not finger pointing, but it's looking at how we can support each other. We are looking at what we can do to support our paramedics and practitioners actually on the front line as CCAM, to see how we can support them get access to our clinicians more easily so that they can avoid conveyance to the acute site. So there's a lot going on at the moment. We have been recognised regionally that we are taking the front step on this. We are working very closely with CCAM. But really, I just wanted to give an overview of where we are at the moment and all of the good work that's going on, but also the fact that we are developing an ambulance handover dashboard, and we're doing that with our teams in ED so that we can share that not only internally but externally, regionally, and with CCAM themselves. So it's new to us. It's part of the ongoing ED standards, but actually ambulance handover now really does take forefront of a lot of our site meetings. When we are talking in site meetings, not only do we talk about our number of conveyances, but we are absolutely looking at the number of ambulances that we keep waiting, and we do report it in time lost to CCAM. So it's very much a focus for all of our staff with regards to ambulances. So that's a real summary. I know we're short of time, Steve, but I thought I'd just give a bit of an insight into what was been going on.
That's really helpful, Tara. And as you say, we have quite a long history of doing well on ambulance handover here. Jackie.
So there's a surprisingly high proportion of conveyed patients that don't need acute care. Is that because there isn't an alternative, or is that because ambulance people have to take someone to ED? What, you know, that seems important if we could redirect that bit. But why do they come to us now? Is it lack of options?
So I think there is an element of a lack of option, and obviously I'm not going to finger point at colleagues, but sometimes they also have targets as well that they need to convey patients. Working with our CCAM partners to try and again look at alternative methods of communication so that paramedics can contact a clinician to ask for advice. And I think the other thing that we've got to remember is that those paramedics are often on the front line and dealing with it in real time. We're calling it sort of the Amazon Prime effect of COVID, in as much as patients want action and they want it now. So we are supporting our colleagues with that and looking at how we can prevent that. And as I said earlier, make sure we get the right care in the right place at the right time with the right provider. So we are working through this audit now and sharing our outcomes with CCAM so that we can work together to see what we need to do differently. So as I say, we've been doing it 2 weeks. It is time consuming because it is a 2-level clinical review. So we've done 400 at first level and 200 at the second level. So we're meeting with CCAM and going through that data and ensuring that they recognise it as well, because that's really important, that it's not just our data and our opinion, it's a shared position going forward.
And are we measuring also sort of peaks and troughs of during the day when that's okay?
Absolutely, yeah, we see that all the time.
Thanks.
Great, thanks, Sarah. Apologies, everybody. My screen has just my screen has just gone. I've lost everybody. Nikki.
Thank you, Steve. I was just wondering, sort of, I guess 2 linked points. One is what happens next. So obviously this is something we've been asked to look at nationally, so it's come to us. Is there a plan that this comes back in a certain number of months to update us on our progress, or does it only come back if red flags go up because we've sort of materially changed in the national rankings? And then I guess my second overarching point is, Tara, when you speak to this, I got a really good picture of why you're doing what you're doing. I'm not 100% sure the paper conveyed that quite as convincingly. So if this is something that's going to come back, what I'd love to see is a slightly tighter link between how we've diagnosed what the problem is. So there's a reference in this paper about 98% of delays due to no space. So, but I think you've then talked about much more broad reasons as to why it's really challenging at the moment. But a real strong link between what we think the problems are and then what we're doing about it, and when we think that might kick in and how we're monitoring it. So we can really get assurance around that whole process.
Yeah, so I think this is the ask is that Trust Board is cited on ambulance handover. I think we'll take it offline as to how often we'll bring it back. And to sort of answer your second point, Nikki, this is moving at pace. So when I wrote this paper a couple of weeks ago, this was just sort of the first iteration. I can't tell you the amount of work and effort that has gone in. And like I say, it's been longer than 2 weeks because I actually did cheekily have a holiday that we wrote this paper. So I wrote it before I went away. And in the 2 weeks that I've been away, there's been the week I was away and the subsequent week, we've done all of this work. So I think, yeah, you're quite right. And actually, next time there'll be a whole amount more that we've done. And hopefully we will see that the whole economy has stabilised a bit and the demand has stabilised and we can start doing some real focused work.
Thank you, Tara. Like I say, when you talk to it, it's a much more reassuring picture.
Yeah, absolutely.
Thanks, thanks, Nikki. And I think ambulance handovers, as I've said before, has always been important to us. We've always done well. We haven't always talked about it because, you know, you often don't. One doesn't tend to talk about the things that we're doing as a matter of routine. I think, given the national focus on it, to Nikki's first point, I think if things do materially change, Tara, it would be good to get a kind of heads up and you know, and what are we going to do about it? Yeah, okay, great. Any other questions for Tara?
Just one point there, Steve. Would you like me to include it into the IPR pack probably every quarter? Would that be helpful?
I think it would. I mean, I'm mindful that we there is so much we could put in the IPRs, but it's a particularly important metric. So I think let's do that. Let's do that for now and kind of review it in a year's time. Good. Thanks very much, Tara. Learning from deaths, David.
Thank you, Chair. I think you're all used to the format of the dashboard now. You've seen it many times before. As you'll see, the number of deaths reviewed is now almost 100%, and that's because we have the medical examiner system up and running and working well. This particular quarter, there was one probably avoidable death, and for those of you who look back at previous ones, we've added one for Q4 last year, which wasn't there on the previous iteration. It was a death that came to the review group late that we felt was probably avoidable. Apart from that, I don't think there's anything specific I want to bring out, but I'm happy to answer any questions.
Thank you, David. I'll see if colleagues have anything they want to raise.
Thank you.
No, thanks. Thanks, David. So let's move on to item 10, the board assurance framework.
Thank you, Steve. I'd just like to bring colleagues' attention to the Q4 report. This is the year-end BAF. As Nikki and Damien both alluded to, the only BAF risk that we see changing at this Q4 is the finance risk, for reasons that I think have already been well articulated. Again, I think looking forward as this report, excuse me, as this report talks to, what we will be doing for next year is just having another look at the risk appetite and reframing, given all of the conversations that I think we've had in the first half of this board, reframing those risks and making sure that they are pertinent and they are relevant to the kind of scale of challenge that we have going forward. We've also talked to colleagues before about what we'll see in Q1 is a slight change in terms of the overview of the reporting. So we'll have the risk assurance radar. What we're doing at the moment is also looking at other organisations and how they present. We've looked at a number of leading trusts, and the good news is, and again this is supported in the assurance that we're getting through TIA, we know we're not miles out in terms of the way that we look at the board assurance framework and what we include in it, but we are making sure that as we go into 22-23, both the content and the presentation and the overall package and presentation of it is where we want it to be. I'm happy to stop there and take questions from colleagues.
Thanks, Richard. Could you just say a word about what the process will be and the timing for doing the reset of the BAF and the taking a look at the risk appetite.
So that will be going through all of, so the next update to the board of Q1 will be in August. So between now and then, what we'll be running through is each of the committees will receive the revised risk profiles for each of the BAF risks that the committees review, presented by the exec directors, and we'll just sign those off through the committees that will then feed into the August update in Q1 that comes to the board.
So that sounds as though we need to have the more general conversation about, I hate the phrase risk appetite, but that kind of overall view as a collective group needs to take place, presumably before that more granular discussion at committee level, does it? So would I'm thinking, would something like a June or July seminar?
We can certainly include it. We can include it in one of the board seminars. I mean, we currently have risk appetites set against each of the BAF risks. I think we can get committees to review whether those appetites are still the right ones, and we can review that as a board, if you like, at the seminar.
Okay, well let's maybe take that offline.
Sure.
Let's take that offline. Whether that's quite the right process, maybe. Inventing a process in the public meeting is not the most sensible way for me to proceed. So questions for Richard? Jackie?
There was just one on BAF1 about cardiology cath labs breakdown. And it's still staying at 16. I thought we'd done quite a bit of work on replacing cath labs. Is it still really 16?
Chris wants to respond to that.
Yeah, I'm happy to respond to that. I think Jackie, the answer to the question is yes, it's still a high risk. We've just finished Conquest upgrade, and now that's now working on the first few patients have gone through. But Eastbourne is due to be replaced this year, and that's still having regular breakdowns. So I can't speak for the medical division, but I know it's high on the agenda to do that refurb this year.
Okay,
thanks. And David?
Just to say that the cath lab is open this week at the Conquest. So given the fact one of our two ancient labs has been replaced, I suppose one could argue that it should be reduced slightly. But the other, the Eastbourne lab is, as Chris says, still breaking down, but will shortly then be closed for its refurbishment. And so we'll then be running on a moderately old lab at Eastbourne and a brand new lab at the Conquest. And so the risk of breakdowns, hopefully, should then diminish considerably once we start the work on the Eastbourne lab.
so we can be reviewed then at next review. That score might change.
Absolutely.
It should look very different from the 22-23 BAF, shouldn't it? That's for sure.
Okay.
Okay. Thanks very much, Richard. Let's move on to maternity, and I just want to be clear that notwithstanding what I said before about being a bit behind the timetable, we take whatever time we need to cover the ground that we need to cover for this item, and pretty much everything else can go by the wayside if it were necessary to do so. So Vicky, are you? I know. Brenda is joining us. Vicky, are you starting us off?
Thanks, Chair. I will, if that's okay. And we are joined by Brenda and Alison. Just a couple of things I'd like to say, not just because I'm the board and exec maternity and neonatal safety champion, but just as the chief nurse and as a clinician of 33 years in the health service. And some important things to say, I think. For those who haven't yet had a chance to read the final and second report from Donna Ockenden, within those 235 pages, I think it's very important to understand that this is a report that reviews almost 1,600 incidents over almost 50 years. The 4 pillars that I mentioned within the report relate to safe staffing levels, training, learning from incidents, and listening. There are 15 essential, immediate and essential actions, and within that there are 92 specific requirements. I would say from a personal perspective that the report is about far more than that. And it, I think, is also about leadership. It is about systems and processes. It's about governance, and it's about transparency. In my 33 years in the health service, sadly, I have read a number of independent reviews, including the MID staff's report and subsequent reports from Robert Francis QC. I've read testimonials from patients, from staff. I've read notes from the inquiry where staff have been cross-examined, and in particular, I've read those witness statements provided by chief nurses in those examples. And the first and very important question that I always ask myself is, could that be here? Could that happen here? So I think it is absolutely right that as an organisation and as a board that we ask ourselves all of those questions. I would say, and I will explain why, and hope that Brenda and Alison will support that, that I don't think that that could happen here, and I don't think that for a number of reasons. I think as an organisation we are transparent. I think in terms of our leadership and our governance, I think we have robust systems and processes in place. We do have workforce challenges, we know that. Every organisation has very similar challenges. And I think our monitoring is robust. We have detailed discussions at every Quality and Safety Committee with regards to maternity services. We have detailed discussions in the performance review for maternity and the maternity assurance meeting. We work collaboratively with our partners across the system in the local maternity network. We have never, to my knowledge, had a focus on caesarean section rates. We support the choices of pregnant people, and our quality indicators do not show cause for concern. We discuss staffing on a daily basis, and we have mitigations and clear escalation plans in place for that, and adjust service provisions accordingly. However, that certainly doesn't mean that we should be complacent or that we are complacent. And I recognise, I'm sure, that the board and particularly our non-exec colleagues will have concerns about the Ockenden report, and I'm sure we will all continue to have all of those discussions to ensure that we have very clear assurance for ourselves and for the people that we serve, that the things that have happened tragically at Shrewsbury and Telford cannot happen here. So this is the scheduled update for the board, and it does indeed contain information regarding progress against the recommendations from the Ockenden report and the Morecambe Bay report. It also contains an update on the workforce plans, as well as a maternity perinatal quality surveillance update. The detailed report is discussed at every Quality and Safety Committee, and Amanda is our non-exec maternity neonatal safety champion and joins me on a number of calls where we have open forum discussions with our frontline staff. The final Ockenden report has just been published. That was published on the 30th of March, and the gap analysis for that, as you can imagine, is already underway. And we've had a number of discussions with colleagues across the system last week and this week in terms of next steps. There have also been a large number of letters and requests for information and self-assessments from our colleagues at NHS England, and we have reviewed all of that correspondence and can confirm compliance with all of those requests. We also have monitoring and compliance, and I would say that I do have a concern, and I have spoken to Joe and others about this, and Amanda, that I think with the final Ockenden report now and the additional essential actions and the specific requirements, that the amount of work required to provide that evidence and that assurance is really very significant. And I think as an organisation, we need to make sure that we have the right resource in place to do that. The maternity dashboard is being reviewed, and we will ensure, of course, that there is board oversight on that and all of the key quality metrics. Chair, I'll stop there. We'll take the report as read, and I'm sure Alison and Brenda will be very happy, as I am, to take any questions going forward. But it's probably more helpful to ask in terms of the update if there are any specific questions.
Thanks very much, Vicky. Can I just ask Alison and Brenda if there's anything they want to say in a kind of overarching sense, in the way that you've also done, Vicky, if there's anything they wanted to add rather than just respond to specific questions. You can say no, Brenda and Alison.
Thank you, Chair. I think I just want to thank all our maternity and obstetric staff for all their hard work over the last 2 years, but particularly the last couple of months when it's been extremely difficult in services, and they've continued to give 100%. Did you want me to go through the assurance letters, Vicky? Chair.
I think probably just questions. Does that make sense, Vicky? Yeah.
Yeah. Thank you, Chair.
Okay, so let me open it up. Amanda, you've been closer to this than most of us, so I'll take Jackie's question first. But I'm going to come to you. I'm going to come to you anyway, whether you've put your hand up or not, if that's all right.
Of course.
Jackie.
Thank you for the assurance, Vicky. I'm just wondering though, where are our risks then? Where do we feel that we need to focus our attention going forward? And I guess I'd like some assurance on escalation policy and senior cover, to give some assurance on that, please.
Sure, and I know that Brenda and possibly Alison will also want to comment. Jackie, I think that there's no doubt that we have workforce challenges, and I think Brenda and Alison and I probably have spoken on pretty much a daily basis over the last, well, certainly the last 2 years, and I think the pandemic has added some additional pressures. So the reasons for some of the gaps in our workforce have been compounded by the pandemic. So when we've had pregnant staff who've had to go on maternity leave earlier, and a whole range of things. We have just had the Birth Rate Plus review of the workforce completed, and actually they re-ran the numbers with a view to looking at whether or not we do need to increase the uplift for our maternity templates to make sure that there's adequate provision for absence in terms of training. So I think our risk is in terms of workforce, but I think that's known to us. It's well understood. I think, and Steve may well want to comment on this as well, but I think certainly in terms of actions that we're taking, then there's a range of measures in place. And I think in terms of escalation, certainly those conversations take place with Tara as the COO, with Joe as the chief exec, with Steve. So I think there's a very clear process of escalation.
Sorry, I meant clinical support, clinical escalation, pardon me.
Sure, no, that's okay. Brenda, is there anything that you'd want to add?
Yes, so we do have a clinical escalation process. We have a manager on call 24 hours a day, 7 days a week. And times when it's been extremely busy, we have a second on call as well, to be able to come in to give actual physical clinical support, and another to sit outside to escalate if required.
So in terms on site, we would have a senior midwife every shift.
So we have a shift coordinator on shift yes, 24 hours a day.
Okay. Thank you.
Thank you.
So Steve,
Amanda.
Even though I haven't got my hand up. So Steve, I think there are many conversations going on in the organisation regarding the safety of our maternity services and our staff. And as Vicky alluded to at the beginning, and her context was really very helpful, In terms of assurance, we are having regular conversations outside of Q&S, inside Q&S, at board, part 1 and part 2. But what we can't do is actually have the conversations that our staff and our leadership are tackling every day, which is the disruption because of COVID, because of staffing, and the sickness absence at the moment is really very high. So clinical choices are being made absolutely every day about what services we can offer, where we can offer them, and how we can offer them to keep our women safe. That's not comfortable. That isn't comfortable, but those are the decisions that we need to take to keep our women safe. That is not where we want to be. We want to use Ockenden to be the platform of ensuring our safe services, but absolutely having equality of access to services. And I think it plays to Joe's earlier point that we will continue to assure ourselves through the committee structures conversations that our services are safe. But actually, we do need to look at how we are going to transform them as part of the evolution of our services. And I think so Ockenden provides the platform for safety and quality, but actually we need to go a step further and think about what is our plan for maternity services in the new world, given that staff are absolutely exhausted and go the extra mile probably every day of their life, if not 24 hours a day, because everybody is being called in on a regular basis to fill in the gaps. So Steve, there are risks. We know there are risks, and we're open about those risks. Have we got all the answers currently? No. But what I am really confident and assured about is the open culture of the conversations that I'm having with senior midwives. Well, Brenda and I spoke yesterday, and with Vicky, and we will continue to do that. So I'm assured about the open culture. There are things that we need to address in terms of capacity, leadership, and as Vicky said, there is absolute admin support that's needed to manage the volume of the data that we're dealing with as well.
Thanks very much, Amanda. George, do you want to come in at this point, or can I take Miranda next? I think I've got some feedback somewhere in the system. Joe, do you want to come in now, or shall I take Miranda next?
It was just a very brief. It was just to say that obviously the report that we've got at board today is an update on Ockenden. What we had previously agreed was that we would do alternate months. We would bring a formal report to full board. However, I think you and I, Steve, agreed that for the next year we should make that every full public board. That report needs to ensure that it's got the maternity dashboard in there, or a version of that is appropriate for full board, recognising we don't want to replicate the whole conversation that's had at Q&S. Yeah. And within that, a bit like we've got, and to be honest, it could just be added into the IPR, so it's a section within that, is that we have got those clarity of risks and mitigations, so that those are really simple to identify and upfront. I think one of the challenges, and we can talk about it a bit more in part 2, is that we obviously need to give assurance about the Ockenden recommendations, but not get so tied up on assurance on that we don't, as a board, focus on the safety metrics as well. And so we'll need to give both elements, I think, at board. So I just wanted to highlight that. And just for a bit of assurance, Brenda and I had a chat yesterday, and Tara and Vicky and I last night, this morning. I've asked Brenda to go and see whether there's some additional, not just admin, but actually some maternity expertise that we can bring in for an interim period of time to build that immediate capacity, because recruitment will take a long time. And I know Brenda's put an additional, or not necessarily additional, but has put an 8A role in as well. So there will be more resource coming in to support Brenda and Alison. So I just wanted to state that bit.
Great, thanks, Joe. Miranda.
Thank you. there's been such a lot of publicity about Ockenden, and the way it comes across in the media is very different from a rather technical checklist, which is how it comes across in the written word, if you like. And you could be forgiven for thinking that either all maternity services in this country are unsafe, or at least 50% are, depending on what you read. So, to be honest, I came into this meeting quite worried about that, and I've taken a lot of assurance away from, in particular, what Vicky said about, she also asks herself the same question, could that be here? And doesn't think it could be. So I take a lot of assurance from that, and also from the fact that there is going to be some help forthcoming, and that colleagues are doing a lot towards this, because there's so much more to this than a list. It is more, as others have said, about leadership and capacity, and I think we are addressing that. So I come away feeling much more assured than I did.
Yeah, thanks, Miranda. And initially we'd set this up as being a kind of conversation about Ockenden 1, if I can call it that. I mean, we've only had the Shrewsbury and Telford stuff for a week or so. It is a sobering, shocking report, Donna Ockenden's second report, and I think, as others have heard me say before, you know, it's about one service in one trust over a period of time, but actually the lessons that come out of it could apply to any service in any trust at any time. So the lessons are much more generic, and exactly as you and Vicky have said, Miranda, you know, the issue of board leadership, service leadership, of professional rivalries, of differing ideologies, of openness and transparency, and governance and resources. You know, we could have read the same thing, couldn't we, about Bristol, about mid-staffs, about Maidstone and Tunbridge Wells. You know, there's a kind of thread that goes through all of these things. So, you know, and I think anybody who hasn't read the second report in a kind of senior leadership in the NHS ought to very quickly, because I think it will, and there's more to come, but I think it will prove to be a bit of a watershed report in a way that some others have been. So I'm confident that it's up the top of the priority list for our colleagues. I'm confident that people are rallying around to work through the issues, both internally within the trust and across the system as a whole. And as Joe says, we're going to talk about this, I think, at every one of our meetings, at least for the next year, and possibly beyond. So there's really important stuff, and I wanted to thank all of the teams who've been working on this over the course of the last year, and particularly Brenda, having kind of stepped up in the course of the last few weeks to take the lead around some of this. So thank you for that. Picking stuff up at a difficult time is very much appreciated, I have to tell you. So there is a further opportunity for more detail a bit further on, but Vicky.
Thanks, Joe. I just wanted to echo my thanks to Brenda and to Alison, our head of midwifery, as well. And I know we'll talk more later, but it has been an incredibly challenging 2 years in particular. So just to thank them both for their commitment and their leadership in still very challenging times.
Yeah, indeed. Joe, anything you want to say by way of close, or shall we move on?
Move on.
We'll just move on. Great. Okay, thanks very much, everybody. seems like an odd segue now to agenda item 12, the review of standing orders. Damien.
Okay, sorry, I didn't realise this one was mine. So we have been through the standing orders through audit committee, and we refined them to a degree just for greater consistency, and it's now about signing off the adjustments we've made. It's basically about being clear about delegation levels, but we are staying in line. We've used UHS as a baseline, and we're approaching this as a standardized approach across the ICS.
Yeah, great. So this is so the changes have been scrutinized by audit, and we're just asked to give our approval. I can see the chair of audit is nodding, so unless anybody has anything that they want to ask, I suggest we approve the changes. And annual self-certification, Richard.
Thank you, Steve. So as the title suggests, this is something we are required to do every year. Essentially, it's a review of the formal terms of our license to operate. There's two documents here. The first is around our corporate governance statement. So as a board, are we satisfied that the arrangements that we have in place for corporate governance? We are, and we've included the evidence to back that up against the 6 areas. The second document covers our provider license conditions with the NHS. And again, how this is what we've looked at is how we are compliant against each of those areas, what the evidence is for that, and who the relevant officer is. So happy to stop there and take questions. But again, this is essentially the annual review, and we're seeking signing off here at the board, please.
And unless anybody has questions or a query, and everybody's helpfully shaking their heads to tell me that they don't, then that is approved. Item 14, also you, Richard.
It is indeed. Again, this is possibly even quicker. I'm asking the board for their approval for the delegation of the annual report and accounts to the audit committee. The board will receive the final annual report and accounts at the AGM in September, but I'm formally required at this meeting to ask for that delegation to the audit committee.
And that's the process we always follow, right?
Is indeed.
And chair of audit is nodding his happiness with that. So unless anybody disagrees, that is also approved. I think I get the prize for the most meaningless item today, and that's to tell you that we haven't used the trust seal since last time. So so that's good. So that takes us to questions from members of the public, and although I've got 3 from Colin Campbell that I'm going to come to shortly, I'm going to see if any of our members of the public who are in attendance have any questions for us at this time. It's unusually quiet. I'm not sure if Liz is on the call. I shouldn't call it a call, should I? In the meeting. So, in which case, we've got 3 questions from Colin Campbell. Certainly 2 of which I think have already been answered in the discussions. His first question is to ask who are the maternity safety champions on the trust board, and we've just talked about Vicky and Amanda being the exec and non-exec leads in that regard. So I think that's the answer to his first question. And he then asked a more detailed question about in the light of Ockenden, you know, how confident are we that if the circumstances that prevail there were to come here, would we be able to recognise it deal with it. And I think the description that Vicky gave at the beginning of that last item will be is the best answer that can be given to that question, and I think we'll direct Colin to that answer when we do the minutes. And Colin's third question asks about is a carryover from the last public board meeting where we had a number of strategy papers, and he asks, are we going to be reporting on progress at every board meeting on each of those 3 strategies? And I thought I would ask you, Richard, for your take on that question.
Thanks, Steve. Yeah, I think, I mean, it's a fair question given the content of the last board. I think the plan that we'd have to update on the progress of both the strategic aims and the enabling strategies is built around quarterly updates, and there's a couple of reasons for this. It's mainly due to the scale of the programs, some of which, as colleagues know, will involve partners well beyond just ESHT. And also, if we bring a review perhaps, well, maybe not every quarter, but perhaps 3 times a year, just because the way that the boards actually fall. But if we bring that regular review back, it will allow sufficient progress to be made in between each of the updates, given the scale of the programs that we're wrestling with. I think from a purely governance perspective, I would anticipate these coming to the strategy committee in the first instance, so that we can get under the bonnet a little bit, and then recommend from the strategy committee the report and the progress that we're making up through to the board.
Okay, that makes good sense as the way forward. So thank you for that. We've somehow miraculously managed to both recover and improve on our timing. I'm just going to give one last opportunity if there are any members of the public in attendance who want to ask a question, but it's not looking like it. Okay, well, thank you very much, everybody. Our next public board meeting will be on Tuesday, 14th of June. And for those who are taking part in part 2, I will see you at 1 o'clock. Thanks very much.